As we reconvene and start into our second half of the agenda for today, just want to send a reminder to PACHA members who are joining us virtually. If you are interested in speaking, please signal by raising your virtual hand, and we will have others who will make sure that they are on alert to be able to recognize you, because we certainly want to ensure your voice and your full participation in the meeting as well. We will move on to the next item on our agenda, and that is around addressing HIV in American Indian and Alaskan Native youth. And it again will be expertly facilitated by two of our PACHA members. I will introduce them each, and then we'll turn the microphone over to them. I will start with our very own Vincent Yamo Ramos, who has just about every letter of the alphabet behind his name. If I counted, I think it might be 13 or 12 of the 26. I don't know, but very impressive. So Vincent is Dean and Professor of the Duke University School of Nursing and Vice Chancellor for Nursing Affairs. He also is the founding director of the Center for Latino Adolescent and Family Health at Duke University. Prior to his appointment as Dean in July 2021, Dr. Ramos was a tenured professor at New York University from 2010 to 2021, holding faculty appointments in nursing, public health, and social work. He was also a tenured professor at Columbia University prior to joining NYU. Dr. Ramos is a nurse practitioner, dually licensed in primary care and psychiatric mental health nursing, and he is credentialed as an HIV specialist by the American Academy of HIV Medicine. Also introducing Kayla Quimbley. She is a youth activist who works to combat HIV stigma, decriminalize HIV, and raise awareness online and in communities. She is also a member of Advocates for Youth, engaging communities around HIV organizing, also known as ECHO, a program that uses a social justice framework to shift culture and policy by elevating the voices of young people living with HIV. ECHO leaders work to increase the inclusion of young people living with HIV in the planning, implementation, and evaluation of reproductive justice-related programs and policies, especially on issues of LGBTQ health and rights, immigrant rights, and sexual and reproductive health and rights. Ms. Quimbley is not only an activist, but she is a traveling poet, working to raise awareness through her words using her platform. I now turn the meeting over to both Kayla and Vincent. Thank you.
Thank you very much, Madam PACHA. So it's really an honor to have an opportunity to co-moderate this session with Kayla and to also introduce our two speakers. There are a couple of things that we're hoping to accomplish this afternoon. One, we really want to take a deeper dive and build on what we did this morning with a particular emphasis on youth, and in particular, American Indian and Alaska Native youth. We also have prepared some questions that Kayla and I would like to sort of offer as a starting point where we can have some discussion once our expert panelists have presented, and then we'll open it up to PACHA and to folks in the room to ask questions. So that's our plan. We have roughly a little under 2 hours, and we're going to try to keep the bar very high because the sessions this morning were just absolutely spectacular. So without any further ado, I'm going to introduce both Stephanie and Kelly. Stephanie, I'll introduce you first. So Stephanie Paz is a Tigua Indian from Isleta del Sur Pueblo. She has a Bachelor of Science in Psychology from the University of Texas at El Paso and a Master's of Public Health and Health Behavior and Health Promotion from New Mexico State University. Ms. Paz has vast experience working in American Indian and Alaska Native health, working with different health boards, such as the National Indian Health Board, the Albuquerque Area Indian Health Board, and the Northwest Portland Area Indian Health Board. She is currently a lead consultant for Good Medicine, Tribal Public Health Consulting. Also joining us is Kelly Avayo, who is a member of the Navajo Nation. She is of the Bitter Water Clan born for the Sun People Clan. Her maternal clan is the start of the Red Streak people, and her paternal clan is the Acoma Pueblo. She is half Navajo and half Acoma Pueblo. Ms. Bayo received her master's degree in social work from Arizona State University. She is part of the first Native American sorority in the nation. And so she's also an indigenous matriarch with the honor Healing Our Nation, offering Resilience Collective, and also has been involved and facilitates an organization that's called Medicine Heals, healing every ancestral linkage through storytelling. And she's also a co-founder of that. There's many more things I could say. Forgive me if I've kind of not gotten all that right, but I think that we are really honored to have both of you here. Stephanie, I think we're going to start with you.
Okay, hello. Can everyone hear me? Yeah. I have a lot of excited energy. So if I'm just off the wall, it's because I'm very honored to be here. And I thank you all for inviting me to speak to the table about American Indian and Alaska Native youth when it comes to sexual health. And I was joking with Callie earlier. So a lot of my presentation, Callie will speak about some of it in hers, but we were just talking about kinship, and no matter what community you're from, we're still tied. So for example, I'm from Isleta de Sur Pueblo, which is people of the sun. And I know Kayla, one of her clans, Callie, one of her clans is Sun People. So I was just saying, just that connection and, interlinkage together is really exciting. But with that, we can go ahead and go to the next slide, please. So good afternoon, everybody. My name is Stephanie Foss. Promise I'm not conceited. Just had this up here in case you have any follow-up questions or want to get to know more about me. But as Vincent mentioned, I received my Master's of Public Health from New Mexico State University. I am also a certified health education specialist, and I wanted to take some time to introduce myself and my connection to We Are Native. So when I was an undergrad, I had learned about the Northwest Portland Area Indian Health Board, who oversees We Are Native. And I decided to apply for their We Are Native Youth Ambassadorship Program. And basically what that does is there's youth ambassadors from across the nation in Indian country who work closely with the We Are Native or the adolescent health team at the board, and they can do some kind of project in their community to promote We Are Native. So I did that as an undergrad for about 2 years. And when I did that, I applied for what they had was a community grant. And in the community grant, I received some funding to do some kind of community health project in my community. When I was an adolescent, I was involved with a lot of health programming in my community around sexual health. And I decided that for my community project, I wanted to do something around HIV and STIs. So with that funding that I got from We Are Native, I taught a class to our youth and their parents about sexual health. And we divided it into 2 sessions. So to not make things awkward between parents and their children, I facilitated the child aspect. So talked to our Native youth who were probably about 12 to 18. And then my mentor gave a class to our parents about talking to their children about preventing STIs like HIV through sexual health practices, safe sexual health practices. And did that for a year, enjoyed it. And then when I graduated, I ended up doing my master's and got reconnected with the Northwest Portland Area Indian Health Board and did my field experience with them. So kind of like a practicum. And from that, I got to work more with We Are Native in terms of developing the content they have on their website and working on the back end. So updating their website and social media. And now I'm a consultant, so I don't directly work for the Northwest Portland Area Indian Health Board or We Are Native, but I do provide consultation based on my work and my expertise. So just wanted to give a little snippet there about how full circle it has been for me, having been involved with We Are Native since I was a teenager and knowing about it in my community, and now being able to be here and talk to you all about it. So very thankful to Laura for letting me speak on behalf of the We Are Native team. They aren't able to be here today, so I just want to give a disclaimer that I'm not the expert in all things We Are Native, but at the end of the presentation, I do provide their contact info. So if you have more information about their programming, I'm more than happy to answer it right now, but your experts are these 2 women that I'll talk about at the end. Next slide, please. So with that, our agenda for today is to talk about the Northwest Portland Area Indian Health Board, and then we jump into We Are Native. And then another project under the Northwest Portland Area Indian Health Board that works with We Are Native called the Washington Youth Sexual Health Project, or WISH for short. And then 2 of their campaigns called Loved Here, Safe Here, or Safe Spaces. And then another one called Get Yourself Tested. And then I'll give you more information about who to contact if you have more questions. Next slide, please. So just some brief history about the Northwest Portland Area Indian Health Board. I know Laura talked about it, but it was established in 1972. They are a nonprofit organization serving the 43 federally recognized tribes of Oregon, Washington, and Idaho. So those are their priority communities, but We Are Native is an online health resource that extends to all of Indian country. And I want to take some time for the land acknowledgement. It's located within the traditional and ancestral homelands of the Multnomah, the Cathlamet, Clackamas, Tumwater, Wadala bands of the Chinook, the Tualatin, Kalapuya, and many other indigenous nations of the Willamette and Columbia River regions. Next slide, please. So We Are Native. We know that American Indian and Alaska Native youth are disproportionately affected at higher rates of STIs, to include HIV, than non-Hispanic white people. So this poses the question, are prevention services reaching our youth? And before the work and programming of the Northwest Portland Area Indian Health Board and partners like Cali with the Intertribal Council of Arizona, there wasn't really any curricula for sexual health education among American Indian and Alaska Native youth. But throughout the years, the Northwest Portland Area Indian Health Board and community partners have really worked hard to establish evidence-based practices that aren't just for sexual health education among youth, but particularly among American Indian and Alaska Native youth. And I know that's something Rydell was talking about earlier. And one of the PACHA members had a question about is how do you incorporate holistic and traditional medicine into Western modern medicine? So I think We Are Native and their sister programs are at the forefront of that, and how to prevent HIV or STIs and promote safe sexual health practices amongst American Indian and Alaska Native youth. And through those partnerships and programming was born We Are Native, which is for Native youth by Native youth. And I think it's a great program that's very different in that the curriculum and all the info that there is, it's not only for Native youth, but it's produced by Native youth themselves. So if we can go on to the next slide, please. Okay, so We Are Native, as I mentioned, it's a multimedia health resource, and its main form took the shape. It's been about, I think, 10 years that it's been active to the public, but its main form is through a website. So if you go on this website, it's very user-friendly. So anybody who can use the basics of a computer can easily access what the services are on this site. So on this side, it's not just dedicated towards sexual health, which I know that's what we're here to talk about today, but there's different topics for Native youth and adults to read on, from sexual health, abuse and violence and relationships, what healthy relationships are, to how to get connected with your culture, and also just different information about different health programming like substance misuse or suicide prevention. So that's all in this online health resource. There is this new service. Before, it used to be Ask Auntie, and Native youth could type in questions on this online health resource, just anything. So, what is a period? Or how can I get tested? Or my partner wants to have sex, but I don't want to have sex yet. How do I talk to them about it? So youth would submit these questions, and it was a quick turnaround time with Auntie Amanda. And she would give you a response where it was a video, but also she typed the response too. And of course, the youth were anonymous, but it would be posted on the website and on their YouTube. So anybody can access, if they had the same question, they could access this info. But now it is Ask Your Relative. And the idea behind that is, we know, and this has always been a thing in Indigenous culture, is two-spirited people. But to be more gender inclusive now, it is Ask Your Relative. And there are different people from the adolescent health team who answer these questions. And I really like this service because I can be asking someone about, I might be a queer person and I can have a question about it, and a relative who identifies as queer can answer that question for me. A part of that is also these text messaging campaigns, which I'll talk about later in the presentation, that youth and even adults can text to 9449 when they type in a keyword. So for example, we have Inspire. Inspire is a campaign for Native youth who want to learn more about the public health profession. So say they're in high school or they're a university student in undergrad. and they want to know more about what the field of public health can offer them, they can text this number and they'll get weekly messages, kind of just engaging them more in the process of public health. But that's not all. There's very different programs or various different campaigns. So for example, the LGBTQ2S campaign, if they're maybe identifying with that identity and they want more information, whether it be coming out to their parents or just more info about who they are, they can text that. I personally am a subscriber, and I have been since high school, of the sex campaign. And that one I get probably, I want to say 2 messages a week. Just different questions or different prompts like, hey, did you get tested? Here's information on where you can get tested. Or today's National Love Day. This day is dedicated to loving communities or people who are in biracial relationships. Learn more about what being in a biracial relationship is and how you can support your biracial friends or biracial relationships. So I'm subscribed to that, and there's just more. So there's a lot of different campaigns that aren't just towards sex that we'll talk more about. And although I said that they are an online health resource, they've expanded their social media reach. So they're active on Facebook, active on Instagram, on Twitter and YouTube, but most importantly, and I'm sure PACHA knows this and everybody else in the audience, TikTok is a big thing right now amongst our youth. So they have a huge reach on TikTok, and in those videos, they'll just talk about anything and everything related to health and talk about testing and sexual health. So next slide, please. So these are the campaigns. We have Inspire. That's a new one, like I mentioned, for public health professionals. And the Northwest Portland Area Health Board does a great job of partnering with other organizations. So with this one, they're partnered with We Are Healers to promote public health professions, like even being a provider, a pharmacist. Then we have Brave. That one is for youth who might be struggling with mental health. So these are like very beautiful promotional messages about why you're important, why we need you here. Then we have Tech STEM. So if somebody's interested in the STEM field and they want to learn more about it as a youth, they can text this number. Healer have, again, similar to Inspire, they have questions about becoming a health professional, but in the aspect of being like a physician or a nurse, they can text this number. Same thing, the LGBTQ messaging campaign, caring, so any uplifting words that they need, fitness, and sex. Next slide, sorry, I didn't indicate. So as I mentioned, we have Ask Your Relative. So Ask Your Relative is a team of educators, public health professionals, and caring adults supporting Native youth through a Q&A service. Here, Native youth can ask a variety of questions ranging from how to flat stitch to snagging, or sex is how we refer to it. They do their best to provide not only accurate scientific answers about STIs or anything, but also from a cultural perspective, right? So youth can text this number or message them and ask some questions. But yeah, so you can't really see, but some of the questions, for example, that have been asked are, I've heard there might be actual spirits, nature spirits portrayed in Pokemon. Is this true? Is it acceptable for a non-Indigenous ally to wear and buy a ribbon skirt? So just a variety of questions. And then that's a QR code if you all wanted to see what it looks like. And then just a snippet of videos from the We Are Native YouTube channel. Next slide, please. So as I mentioned, We Are Native, there's a variety of different topics that a youth subscriber can take a look at, but the premise is providing life advice on a wide variety of topics. And right now, there's over 400 health and wellness articles written and reviewed by Native youth and topical experts. And some of the articles that have been written are around my culture, my life, my relationships, my mind, and more. So when I got involved with We Are Native as a consultant, I was very fortunate that they reached out to me to write articles. And you can go to the next slide, please. So for example, these are just some of the many articles that are on We Are Native, but I was fortunate with my expertise and utilization of We Are Native as a youth to write different articles around sexual health. So what's PrEP, right? That's something that we've talked about many times today, but just providing that access to our youth, because our youth, very knowledgeable, but sometimes don't know what they have, the resources they have to them in terms of STI testing and prevention. So help produce an article on what's PrEP. And at the end of every article, we have resources. So it's not just an article that, hey, this is what I think it is. It takes a lot of research I can speak to that because I've written them. A lot of research, consultation with the adolescent health team, review from providers sometimes or from subject matter experts in the medical field, and then hyperlinks throughout. So a youth can be reading an article about PrEP, but maybe HIV's in the article itself. It'll link them to an article about HIV, and then resources about how to get tested or where they can access PrEP. Recently published an article on the real story about dental dams. So when we talk to youth, sometimes they know about condoms, right, for vaginal, anal sex, but don't really think about oral sex. So providing that information about what dental dams are. We worked really hard to revamp the website. So that's something I've helped with the past year, is working on the back end and working with people to update our website. And what I mean by that is gender inclusive terms. So before we would call internal condoms, female condoms, right? Because they go inside the vagina. But working with the team to update that language, because we know not everybody who has a vagina identifies as a woman. So just updating that language and giving them instructions on, okay, you know, this is a condom. How do you put it on? What do you need for it to protect you from STIs and unwanted pregnancy? And then another one, how to use an external or a male condom. And then just a bunch of different information that's medical. So what's an STI? What's chlamydia? How can I get treated for it? But also a little bit more conversational tips. So how do I talk to my partner about using protection? You know, my partner doesn't want to use protection because they think it makes them less of a man. But how can I have that conversation with them to let them know that I want to use protection? We talked about native tests today. And that's an article that I helped write, is getting tested for HIV. So what is HIV? How can I get tested for it? Condom shopping guide. So information about, you want to know what kind of condom to get depending on the stigma of your size or your pleasure. So here's a guide we have to help you shop for condoms. And you know what's funny? Because when I've talked to youth about this, it's a little awkward, right? Because it's like, why are you telling me what kind of condom to use? But we try to make it as relatable to them and as just open. So it's not taboo. It goes back to destigmatizing HIV, destigmatizing these conversations around sex with Native youth and letting them know, like, yes, it might seem a little weird, but let's just have a frank conversation. We just want you to protect yourself. And that's exactly what We Are Native is. And then, of course, we have information about HIV. And I know as a subscriber, I've gotten texts like on National HIV Day, on to get tested, where I can go for condoms or any type of barrier method to protect me. Next slide, please. Before I go into Native Voices, I did want to mention, and Callie will speak to this more, but We Are Native isn't only an online health resource. It can be used as an evidence-based curriculum with Native youth. So if you access the site that Callie will talk more about, providers or, for example, community health workers can go on We Are Native and see that they can establish a curriculum that's 10 sessions in their community. And it incorporates culture as a protective factor. So yes, it provides scientific information, evidence-based information about STIs, preventing suicide, but it's with that Indigenous component. So I just wanted to mention that it's an actual curriculum that can be used. And it also teaches youth how to use online, the We Are Native as an online health resource. So I did have a video for you just to give you a little snippet, but they couldn't play it, unfortunately. But one of the programs or programming that the Northwest Portland Area Indian Health Board has that also falls under a We Are Native is called Native Voices, which stands for Video Opportunities for Innovative Condom Education and Safer Sex. And these are about 22-minute long videos, and it's a video series of about 5 episodes, I think. And it just encourages condom use to prevent STIs, HIV, and unwanted pregnancy in Native country. But what's really cool about it is that all Native funded, all Native actors, and provides very real scenarios for Native youth. So in this video, it's a couple of Native youth who are going to a supermarket and they're trying to buy condoms, but they don't know what condoms to get. And, you know, as Native youth, we know, sorry, I'm like eating this microphone. As Native youth, we know our elders, or not even Native youth, Native adults, our elders are really sacred to us. And it's kind of what you say goes. And if you have any questions, you go to your elder. So in this video, they're looking for condoms and an elder comes up and he has this stern face. So they get scared, like, oh my gosh, like, what's he going to say? But it takes a twist on humor because the elder says, oh, the minty ones are my favorite, and grabs a box of condoms. Yeah, I really wish I could show you. And the Native youth are kind of laughing like, oh, okay, you know, like we kind of got approval from our elder. He's cool. He can hang out with us. But it's just this idea that your community is there for you. And, you know, even people that might surprise you, like your elders, are there to give you wise information, even about awkward taboo topics. So in a couple of the other videos, they talk about like, it's an instance between a Native boy and his Native girlfriend talking about STDs. And in the end, one of them gets chlamydia because they cheat on their partner. But it's like, how do you bounce back from that too, right? Like, okay, you got tested for chlamydia, you test positive for it. How do you bounce back from that? And having those conversations too with the person you infected or might have infected you, and then the person you cheated on with. So it might seem a little like, whoa, you know, like he cheated on her, but it's just realistic conversations and scenarios that happen. So this video talks about that and shows you how to have those conversations with those you're intimate with. But I really hope you all can see them. But I know I was told to send them to Caroline, so she can send them out to you all so you can look at them later. Next slide, please. And then this is just a little snippet of We Are Natives impressions. This is from 2021, so of course it's improved since then. But in 2021, the page itself got over 350,000 views, page views, and then 1.65 million total views. On YouTube, over 1 million, almost 2 million impressions are made, and that's just basically people who subscribed, watched the videos, commented. Facebook also has high impressions of about 1.5 million, Instagram 880,000, TikTok 973,000, but I can imagine that's well over the million now in 2023, especially TikTok. Twitter 457,000, and then 2 million SMSs sent, so 2 million text messages sent to Native youth. So yeah, a lot of people that they're reaching. Next slide, please. So now I want to talk about the Washington Youth Sexual Health Project, or WISH. And basically, this is kind of not a subsection of We Are Native, but they work closely with We Are Native to also provide sexual health information. Am I good on time? Yeah, okay, thank you. May you go to the next slide, please? So the Washington Youth Sexual Health Project partners, it's with the Northwest Portland Area Unit Health Board, but they partner with the Washington State's Department of Health Youth Sexual Health Innovation Network. And the purpose of this campaign is to improve youth's access to experience with sexual health care in the Indian, tribal, or urban Indian health clinic settings, including sexual health services for our 2SL LGBTQ teens and young adults. So this one works more with providers, which is something we talked about today. How do you provide that access to care from a provider perspective? And I believe, Madam Chair, you also had mentioned earlier about gender affirming care as well. So this targets providers on how to provide that access in a respectful and an Indigenous respective way to Indigenous youth. And then this is just a little promotion of Take Pride in Yourself. Next slide, please. And when I say Indigenous, for me, it's interchangeable with American Indian and Alaska Native youth, which is the target audience for this. So one really nice thing about WISH is that, again, within the past year, We Are Native has had a revamp in their sexual health content to be gender inclusive, but also to talk more about relevant information, for example, like U equals U, PrEP being there, the Native test. So fortunately, WISH was able to fund that updating of the sexual health content. And through this funding and We Are Native, I'm working with the youth right now. So they take pride in, like I said, for Native youth, by Native youth. And all of that is the adolescent health team. They hire external youth. So for example, one of my Native youth in my community who identifies as male, which we always need male writers, right, to give a male perspective as well, or people who identify as male. They recently got onboarded. So they will pay youth. They'll reach out to youth from across Indian country and let them know, like, hey, we're paying you $100 per article you write. So really tailoring that it is from Native youth themselves and talking about their experience as a Native youth And then, of course, the adolescent health team or like consultants like me will review the article, work with them to craft it and send it back. So I think it's a win-win because it's helping them get money as a youth, but it's also helping shape them as like a health communication specialist in some way and making an impact in public health without them really knowing it. So yeah, amazing. But yeah, so WISH funded the sexual health update of that of the We Are Native website. And then what's something really cool that I love about them that I've never heard about this, even in my own community, is funding snack bags or free culturally relevant safe sex kits that are discreetly mailed to Native youth. So of course, the priority is Idaho, Oregon, Washington, those tribal communities, but they will send them to anyone in the nation. So they'll send it in a packet that's discreet, right? Because I think that's a worry for youth. Like, is my parent going to see this, or are they going to find out that I'm sexually active? But they'll send it completely discreet. And in that, there'll be external and internal condoms, lubricant, insertion and removal direction. So how do I put a condom on? How do I dispose of it? Hand wipes and more. So that's really nice that WISH does that. Next slide, please. And then again, from that, they have two campaigns, some other campaigns, which are Loved Here, Safe Here, or Safe Spaces, and Get Yourself Tested, or GYT. Next slide, please. So Loved Here, Safe Here, they offer materials for tribal clinics and those who engage with Native youth to provide and support an affirming environment for the LGBTQ community. And what they do is they provide stickers for tribal clinics to pass out, posters so they can put in their waiting rooms, temporary tattoos, virtual backgrounds, and graphics. I've been in a couple of meetings with people where they have this Loved Here, Safe Here background, and it kind of makes you ask like, oh, what is that? And then they'll give you information on it. And then just more. So more promotional materials to offer tribal clinics so they can let their population know that they're loved here and safe here, no matter who they love or how they identify. Next slide, please. And then Get Yourself Tested. So I know this is a huge campaign with the CDC, but the indigenized version of this is it encourages young people, Native youth in this instance, to get tested and treated for STIs and HIV to protect their health and the health of their partners. And they do this in the form of videos and also virtual graphics and backgrounds that you can use like on your Zoom or as your Facebook cover photo, promoting it on social media. Next slide, please. I did have a video, but again, I'll send it to Caroline so she can send it out to everyone. And this is basically just a Get Yourself Tested commercial. And what they did, and I love that they do this, is, oh,
we are
perfect.
Two-spirit, lesbian,
gay, bisexual,
transgender, questioning.
Don't lie to me, you could play it. Just kidding.
For HIV and sexually transmitted infections.
We not only respect and protect ourselves,
but we respect and protect each other. Be yourself.
So yeah, the idea is be yourself, take pride in yourself, get yourself tested. And what I really love about the imagery of this campaign is we have Afro-Latinos or Afro-Indigenous people. So I really like that they're included in that imagery too. And it's kind of a message for all Indigenous people, no matter what country you're from, get yourself tested. I think Natives, we really pride ourselves in community health. And I know that's something across the board for all populations of public health, but definitely like it takes one person to affect the community. And instead of from an individual health perspective, which is just as important, it's a community health perspective. So not only protect yourself, but protect others too by getting tested. So that's a message that really gets pushed across. Next slide, please.
We are who we are. Two-spirit.
Oh, you can press the next one. It's just replaying the video. So again, I am a consultant and I'm very grateful that I was asked to be here as a We Are Native youth, which means a lot. I just turned 26. So I'm like, heck yeah, call me a youth as long as you want, please. But I'm very honored that I was asked to speak at this just based on my experience as well. So I'm very fortunate that again, not only have I had the opportunity for the past year and a half, 2 years to work with We Are Native, but I feel like I'm a living proof of it. Before I even started working with We Are Native, I would utilize their resources a lot in high school, talked about it with some of my Native friends on res, like, hey, this is super cool, got shirts ordered from them, got free condoms. So I genuinely think I'm living proof of how it can impact you. And through them, I really learned the importance of getting tested every 3 months, always talking to your partner, no matter the kind of relationship or committed relationship you have with them, the importance of getting tested and taking care of yourself. So I'm just really grateful I get to speak on behalf of that, but also from the back end on working on the website too. So if you have more questions about WISH, We Are Native, the best person to talk to would be Selena Ghost Dog. She is Navajo and she's a project manager. So again, I know you all have them printed out in your binders, but her contact information is there. Next slide. And then Asia Brown. So Asia, she's from Choctaw Nation of Oklahoma, but she's a sexual health communication specialist. So she really works hard to push out content, not only on the website, but also on social media. So anything you see that's pushed out, it's Asia doing it on the back end. So if you have more questions about like the media aspect of it, she'd be the best person to contact. Oh yeah. I also asked Cousin too. So she'll do like videos on Instagram and TikTok where it's like, hey, Cousin Asia here, just like following up with you and talking to you about these health information or this health information. But again, I just want to thank you all. If you have any questions, I do have my email up there. Again, I am with Good Medicine, a public health consulting service that offers consultation to Native health organizations. Thank you all.
Thank you, Stephanie. Stephanie, we're going to hold questions until after Kelly presents, but Kelly, if you would please give us some wisdom.
How do I like do that? Like, I'm just like, wow. So hello everybody. Yat she Kelly Ray Vayo Yinche. Twitchini in the slow Jonah Aid Neighbors Chin. There's Chini dash check or need an aid dash another. In leader a nasha de quide hos dot so hol yehigi a con shogun. So hello everybody, my name is Kelly Bayo. I am of the Bitterwater clan, born for the Sun People clan. My maternal clan is the start of the Red Streak people. My paternal clan is the Yakima Pueblo. I'm originally from Chinle, Arizona, but I currently reside here in Phoenix, Arizona. I'm also the Native Youth Coordinator with the Intertribal Council of Arizona. I got my I'm already like being res here. I received my bachelor's in social work as well as my master's in social work from Arizona State University. I will be starting my doctorate's program with Arizona State University. And y'all have to help me convince Stephanie to also get into the program. A lot of the accomplishments that I have completed this year was being the co-founder and co-host of an Indigenous professional support group called Medicine Heals. Heals being healing every ancestral lineage through storytelling. That is through the National Association of Social Workers through the New York State chapter. I also am an honor matriarch with the Honor Collective out of Tucson, Arizona. We provide healing to the community through Indigenous art and storytelling. I interchangeably use Indigenous as a way of identifying our community and our nations, our bands, our villages, only because of we are all global Indigenous, whether it's First Nations, North America, or the southern region, Southern Americas, as well as those overseas. So I do use global Indigenous or Indigenous. So Stephanie said, I'm still a youth, and she is still a youth. But in my age, and I don't want to tell my age, but I would be I fit in the category of the auntie stage. So, and a funny story, like Stephanie was talking about relations. And so, when Rydell Curley was talking about relations earlier in his presentation, in all of the Indigenous communities, Native American communities, we do all show forms of relation, whether it's through patrilineal and matrilineal lineage, or whether it's through clanship. And most of the time, whether you're related by blood or not, we know how to identify those that we call relations to. So those that are older than me in this room are either going to be my uncle or my auntie or my grandma or my grandpa. Those within the same age range as I am are going to be my sister or my cousins. Those younger are going to be my little sister, my little cousins, or my child. And so within the indigenous community, specifically the Navajo community, those that are younger than us, we call Shiaja. So that's my baby or, my little one. And then those that are within my age range are my Shana or my Shede, my older sister, my older brother. And so in indigenous communities, that's how we all show relations to one another. And that's what makes us unique, different from all the other ethnicities out there. So thank you for that little introduction. No, I'm just kidding. Okay, so I'm going to get into I got my little notes here. So excuse me if I Project Red Talon. So Project Red Talon was created to pretty much improve the organizational capacity of the American Indian and Alaska Natives. We wanted to improve STI, HIV, and HCVs through testing, screening, treatments, and reporting. We also wanted to strengthen the capacity of tribal health educators, program managers, clinicians, to provide the services to the local community and tribal nations. Next slide, please. We also wanted to increase, go back to the other slide. We also wanted to increase the community awareness about STI, HIV, and HCV, as well as increase the American Indian and Alaska Native representation in these regional national work groups. Next slide, please. So some of our partners include, we all have a collective effort between all the partners. So we all work together as a collective. We are partners with the Northwest Portland Area Indian Health Board, the Alaska Native Tribal Health Consortium, the University of Texas, the Southern Plain Tribal Health Board, the Intertribal Council of Arizona, and as well as the Indian Health Services. Our main goal and our core strategies is to diagnose, to treat, to prevent, and also to respond. Within these areas, we want to be able to make sure that we are touching up on the topics of prevention of HIV, STI, and HCV. Next slide, please. With Project Red Talon, the project has provided training and technical assistance to tribes and tribal organizations throughout the U.S. We want to implement and evaluate cultural appropriate sexual health and STI HIV prevention programs, and we've been doing this since 1988. This project was actually funded by IHS and the HIV program. So in this deciment, we want to collaborate. We collaborate with the tribes, we collaborate with IHS and other partners as well. And these are in the areas of whether it's tribal communities or partners and organizations that work with IHS or in public health. We also network. We want to make sure that we're improving and increasing linkage to care, to services, to treatment. And we also want to share best practices. And then we also resource. We want to be able to share the resources and materials that are out there that are being utilized by other organizations, tribes, nations, and public health agencies. Next slide, please. So the ITCA project activities, we pretty much identify training and technical assistance. We provide webinars, we connect tribes to resources, we identify other STI, HIV preventional needs, and we also create opportunities for tribes to access and deliver curriculum for youth and high-risk American Indian Alaska Native populations. I'll get into this later in regards to how we do that, but we try to create and provide a lot of resources, a lot of support for communities, whether they're in the rural areas or in the urban areas. With that being said, next slide, please. We do have I Want the Kit, and I know Rick had touched up on this, but with I Want the Kit, it was coordinated by the Oklahoma Area Tribal Epidemiology Center. So it's So it's a program that's available nationwide for ages 13 years and older. And with that is Native Tests, which it impacts the communities with positive change and resources. So here we have the Indigia I Want the Kit availability and expansion. So this map shows what's in progress and what we are working on, what's been available and what's in progress. So the blue states shows where I Want the Kit is available, and those that are in the orange reddish state shows where it's in progress to where it's going to be available. More so, the Native Tests and I Want a Kit, our goal is to make sure that it is provided nationwide across the whole United States, so that it is accessible for those that need that. We were talking about confidentiality being one of those challenges and barriers. This I Want the Kit is an at-home testing kit. So this would be a good way to be able to have those tests, those individuals being tested, whether they're in the rural or in the urban communities. I know one of the questions was, I believe, do you have, any evidence that this worked, or do you have any evidence, or what is the success? And we do have a success out of Alaska. They first started out on trying to get their indigenous community, their indigenous nations, to be able to test, and I think the number was pretty low. But right now, since Alaska's been doing I Want the Kit, they've been sending out numerous boxes to their indigenous villages, and it has been a great success. I believe they started out within the hundreds of just sending out hundreds of boxes, and I believe now it's in the thousands. And so it is utilized there. It is doing very good there. And so that is one of the success stories that we have in regards to how I Want the Kit has been successful. So the Native Tests, or I Want the Kit, it's free upon request. So it's an HIV self-test kit. It's also an STI self-test kit, and it also has information about PrEP. So it provides support to 38 organizations, and 38 organizations are actively participating. Again, that is through that map that I had just showed you. So this is also provided to anyone nationwide. You do not need to be indigenous to have access to this I Want the Kit. The person must be 13 years or older, and they do have access to information on HIV prevention care, and that's through preventive care through PrEP, and they also do free STI testing in these selected areas. When it comes to access to information, should your tests come back positive, there are different regions that are assigned, or different agencies that are different tribal health agencies that are assigned to your region. For example, if anyone tested positive within the Arizona or Southwestern state, they would be connected to, linked to care to the Southern Plains Tribal Health Board. And that Southern Plains Tribal Health Board would be able to find them linkage to care to where they can continue to receive the treatment or get further testing. Each test kit actually comes with an OraQuick HIV self-test kit. It comes with PrEP and PEP resources. It also comes with STI education testing options, as well as linkage to care. It also provides the 988 information and condoms. Next slide, please. So the focus areas is we pretty much leverage and expand HIV prevention. We also do testing and PrEP delivery at Indian, tribal, or urban clinics. We also address the behavioral and social and structural barriers to prevention and care among tribal communities. And this is all within respects to those tribal communities, the villages, the bands, the nations. This is more or less to also give an understanding that not all tribal communities function and are structured the same. Some of the tribal communities are either matrilineal or patrilineal, so it's also getting an understanding of how that works. And also we leverage the We Are Native and the Healthy Native Youth campaigns to reach teen and young adults. And those are the campaigns that Stephanie had just spoke about. Those campaigns can be reached to anybody and for anybody. So we'll get into that in the next few slides in regards to how the marketing works in that area. Next slide, please. So Now we are going to be talking. So that was Project Red Talon. Overall, what we do. So Project Red Talon also works with Healthy Native Youth. Healthy Native Youth is a website that promotes curricular resources for American Indian and Alaska Native youth. It's youth development, it embraces culture and teachings, and it demonstrates evidence of effectiveness. So overall, it's engaging, it's relevant, and it's effective. We also, again, collaborate with the Northwest Portland Area Indian Health Board, the Alaska Native Tribal Health Consortium, the Intertribal Council of Arizona, and the University of Texas and Science Center at Houston. So the purpose is pretty much to provide healthy sexual education for anyone who works with the American Indian and Alaska Native youth. And this is within the areas of HIV, pregnancy. Our objective is to promote the Healthy Native Youth website across tribal communities in and outside of Arizona. We also provide training to sites with the ability to select, adopt, to implement, and to maintain the curriculum that they feel best fits within their community. We also provide ongoing technical assistance for training, information, and support within any of the curriculas that they choose. Next slide, please. So these are the 4 main Healthy Native Youth curriculums. Native It's Your Game 2.0, and this is going to be updated, and we'll talk about that further on. We also have Native Stand, we have Native Voices, and we also have We Are Native. Again, these are the 4 main curriculums. However, if you do visit the Healthy Native Youth website, you'll also find 16 to 19 other different programs that you feel would best fit your nation, your community. So it's not just these 4. There's other programs there that you can also take a look at. Next slide, please. So we want to talk about first Native It's Your Game. And so these next 4 slides, we'll talk pretty much about what this curriculum entails and why it's so special. Excuse me. So Native It's Your Game 2.0 is a web-based HIV, STI, teen pregnancy prevention curriculum, meaning everything is done online. This program teaches about healthy relationships. It also teaches about life skills. It teaches about communication, and also emphasizes abstinence and how to protect yourself from pregnancy and STIs. It's for ages 12 to 14 years old. So it's around middle school age, and it could be delivered in school, after school. It could be delivered in community programs, Boys and Girls Club. And it includes at least 13 lessons that are at least 30 to 50 minutes long. Right now, Native It's Your Game is going through a revamp. It's being updated. One thing that's unique about the curriculums is that the youth actually test these programs, they test these curriculums, and they provide us the feedback on how they want us to update these programs. For this curriculum specifically, I think one of the youth that we have is from one of the tribal youths that are testing this program and that have provided us the feedback were from one of the northern tribes. And one of the youth was like, no one dresses that way anymore. You need to update the clothes, or no one talks that way anymore. So we do take those feedback very seriously, and we update it through their feedback to make sure that it is relating to the youth within their community. So more or less, this is not so much feedback from not just the professionals. We really utilize feedback from the youth because this is for youth by youth. Next slide, please. Native STAN is Students Against Negative Decisions. So this is a comprehensive sexual health curricula for Native high school students. It focuses on healthy relationships, healthy life skills, and sexual health. It also contains stories from tribal communities that ground cultural teachings and learning from cultural teachings. It's also trauma informed and it's two-spirited LGBTQ plus inclusive. So this is actually utilized with one of our agencies here in Arizona. The agency is called Native Health, and in the behavioral health department, they are utilizing the Native STAN, and that is one way to where they're able to connect therapeutic interventions with cultural learning and teachings. Next slide, please. So this is Native Voices, and Stephanie touched up a little bit on this, Voices being video opportunity for innovative condom education and safer sex. So it's an HIV prevention program. It's evidence-based in sexual health videos for all American Indian and Alaska Native teens, as well as young adults for the ages of like 15 to 24 years old. It also uses video and role playing to decrease the decrease the rate of STI. The toolkit materials, it'll include Native Voices videos, condom and dental dam demonstrations. It also includes a selection of condom and dental dams and a user guide. Next slide, please. And we also have We Are Native. And so Stephanie touched up a little bit on We Are Native. We Are Native can also be used as a curriculum. It's about students taking control of their own health and well-being. It's a 10-session guide which offers fun and innovative and interactive lessons. It promotes positive youth development and healthy decision-making. The goal is to spark a positive community engagement across Indian country and to inspire young people to address the issues that affect them. They also have the Q&A discussions, which is ask auntie, ask uncle, ask cousin, and ask relative. So the point of We Are Native is also to provide that kinship and to also provide that family. And when we talk about being able to go to auntie, uncle, cousin, or relative, you want to be able to provide being that askable adult. So we're not only creating a trusting environment and bridging that gap in regards to the support that they need. We're also able to provide that through this through the website and through the curriculum. Next slide, please. Next, we want to talk about the implementation toolbox. This is actually for organizations or agencies that are trying to find a curriculum that best fits for their agency or their community. It helps you walk through the important phases in the planning. The important phases, as you can see, the icon is a little bit light, but you can see it's not linear. It's more of a circular motion. So the phases are the gather icon, the choose icon, the prepare, the implement, and the grow. And so the implementation toolbox comes with templates in regards to a community needs assessment, a template in a memorandum of understandings, and classroom engagement strategies. It's also to help find the appropriate curriculum that best fits your community, but it's also a template that you can use for your community and whatever program you feel like it would need to adopt or whatever program you want to create in your community. So it's not just so much exclusive to the curriculum on the Healthy Native Youth website. It's for also tribal communities, nations, villages to help them figure out or help them find what their community needs. Most of the time when you're like, okay, so here's your grant money, let's have you create a program that deals with youth and, you know, the safety and the prevention of something, something, something. And most of the time you're like, oh my gosh, where do I start? So this is a step-by-step process in regards to how you can create that program and what templates there to how you can start or how you can word that. And so it can get overwhelming because when I explored it, I'm like, oh my God, but it is very, very helpful. Next slide, please. So the next we have our community of practice. The community of practice gathers once a month to share our strengths and knowledge in improving the lives of Native youth. So anyone can join our community of practice, and it includes new resources and opportunities. We just completed our part 1 and part 2 series. We are currently in the works of creating the next series coming about, but the part 2 series was about taking back taking the power back. The thing is though, is even if you miss the opportunity of participating in the community of practice, if you go to the Healthy Native Youth website, you can click and look back at the past webinars that we've hosted by just clicking on where it says register here. There's going to be like light areas where you can click and you can go back and you can look at the past community of practice webinars. And with the community of practice, we share resources, we share curriculums, we share programs, we share advice, We share just pretty much anything in regards to how do I get the community engaged? How do I reach the adults? How do I reach the youth? And so this is pretty much where we as all professionals, and you don't need to be a professional. You can even be a parent. You can be a teacher. And you can even be a student who wants to join and just kind of give your feedback, your suggestion in regards to how we can work together. What's great about the community of practice is we don't gatekeep the information. Whatever worked in, the Northwest Portland area or in the Eastern tribes, we'd be like, hey, this worked here. Why don't you guys try it there? The things as well is that once those resources are shared, you can tailor that to your community as well. So you're able to make sure that you're tailoring it to the audience that you're trying to reach. Next slide, please. So these are the resources that we have. We have the text messaging services, and I know Stephanie touched up on this a bit as well as Rick. So we do have caring messages. So if, and the We Are Native Sexual Health, and this is the one that Stephanie was talking about. If you text sex to 94449, you'd be able to get the information, or any type of support through those text messages. And you can get 2 to 3 text messages a week. We also have Talking is Power. This is for the adults, the parents, in regards to kind of having those tough conversations. How do I start? How do I talk about this? I know Mr. Curley or Rydell Curley talked about how some of these conversations aren't happening in Indigenous communities. And before the colonial experience happened, these conversations were happening in Indigenous communities. They were happening by ways of puberty ceremonies. They were happening by ways of the coming of age ceremonies or the stages of coming of age. When they hit a certain age, you start talking about different responsibilities that they would have. However, during the colonial experiences, a lot of that was shut down to where we were not able to talk about these conversations. One of the things that we want to do within the Healthy Native Youth curriculums and the website is to normalize these conversations again. The more we normalize, the more we're able to prevent and educate. We also have the Talking is Power. And so this is the one for adults having those tough conversations. If you text Empower to 94449, you'd be able to get 3 text messages as conversation starters. It revolves around sexual health, pregnancy, STDs, and consent. You can also take a picture of the QR code and the resource page that you see on the right-hand side where it says youth resources, it would be able to pop up for you. The great thing about this youth resource page is it's downloadable into a PDF form, so you can send it out electronically. You can print it out. You can even just send a QR code if you're doing presentations, or if you're like, hey, how do I get these resources out? You can just show this QR code and it will take them directly to the resource page. This resource page is 3 pages long, but the great thing about that is I'd rather have 3 long pages of resources than just 1 page of go to your local emergency, whatever. You want to make sure that you have all these resources. It touches up on everything. It touches up on Two-Spirited LGBTQ, on bullying. It touches up on safe sex, even college. When students leave for college, it's a definite support. What's great about this too is that all of our children nowadays, they all live through their phone. So, for example, I have to text my daughter, come to dinner, right? And so now I can be like, here's a resource if you need help. And so one thing that's great about this is that even though there's a gap in child-adult conversations, it's also a way for them to learn how to research these resources on their own. And again, this is great too if they want to research local scholarships, or if they want to research. So this is actually a way for them to explore, research, and find that support that they need, and then coming to us and being like, hey, this is what I found. What do you think? So, I mean, it's a double-edged sword. Sometimes it's like, hey, there's not enough communication, but it's like, hey, they're learning how to explore. And so it's always looking at that on a positive level. Next slide, please. And so for the project Red Talon, the point of contact would be Gwenda Gorman. She's the Red Talon ambassador. She's also the Intertribal Council of Arizona, and she's also my supervisor. She unfortunately could not be here today, but she would be the main source of contact in regards to Project Red Talon. And I am the point of contact for the Healthy Native Youth website and resources. All of our information is in your binder, and I also have business cards. So if you would like a business card, then we can definitely exchange. And that concludes my presentation.
Thank you, Stephanie and Kelly, for that wealth of knowledge that you just gave us. We're going to ask a few questions, and then we're going to open the floor for questions from PACHA. Our first question is, what is being done to address HIV in Native youth?
So I think we spoke to that earlier. We have amazing programming right now in place to address the HIV epidemic in American Indian and Alaska Native youth. I'm really excited to hear, Kelly, that Native It's Your Game is getting an update, because exactly like she was saying, I've worked in other programming for Native youth, not particularly around HIV, but where we test it with them and say, hey, what do you think about this? And it's like, nobody says lit anymore, or like nobody says this anymore. So we got to update the script. But I think just this kind of programming is being done to help our youth.
And thank you for that question. And I do agree with Stephanie. I think right now there are a lot of programs that are touching up on youth engagement. But I don't think it's just their programs. It's also the conversations. What kind of conversations are we having at home? And I think it's not so much what programs are out there for the youth. It's like, what is our responsibility as a community? What is our responsibility as a family and as a unit? What are we doing to educate at home as well? And so, and that kind of just speaks to all the programs that are out there. All the programs are out there, and all the programs are there to provide these resources. But how are we showing that consistency? How are we showing that, hey, we can do We Are Native, but you're only going to do We Are Native on your time, and then we're going to talk about something else. It's like, how are we showing that consistency in the home? How are we continuing to educate and bring that awareness? And it's hard. I'm a parent, and my daughter was asking me about sex. I'm like, what? And I'm a Native Youth Coordinator. This is my job, right? And I should be like, boom, boom, boom. But I was like, oh my gosh, it's my kid. It's my kid. First of all, you're not supposed to be thinking that. You're not supposed to be doing that. You're not supposed, and so I do get that shot. I do understand, as parents, we're like, okay, blah, 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 I don't want to hear it. But at the same time, what is my responsibility? And so I think right now with the programs that are out there, there could be more that could be addressing this. But I also believe, just coming from a tribal and an indigenous background, being, Native American, all of that starts from the home. And we call that, positive parenting, child rearing, all of that. And so having these conversations is a great start.
I do want to add one more thing to that. So I also think it's what's being done at like a regional level, or with programs like Healthy Native Youth, We Are Native. But for my experience, I also think it has to do with individual tribal communities themselves, right? And what kind of resources they have, whether it be federal funding, through their community, local funding. So for example, in my community, we actually worked, and I hope she's still listening, but Savannah Jean, who spoke today, during the addressing it in the community in general, who works at the Albuquerque Area Indian Health Board. I knew her when I was a youth, and she came into our community and she helped us develop a TIGWA-based sexual health curriculum. And we use that to this day. It's called TIGWA Cares. So community awareness raises empowered students. And that's just something we have that's tailored specifically to being TIGWA and to our cultural identity. So I definitely think it's what tribal communities are doing on the individual level that may not be publicized like these. So I think every tribal community works really hard in their own capacity, in their own spaces, to utilize these kind of resources, but also make their own. So I definitely think it's programming. And as Kelly mentioned, having those conversations, which We Are Native has Talking is Power, teaching adults how to have those convos with their children.
Awesome. Thank you so much. I definitely think the resources that y'all have are very fruitful very detailed, very expansive. So in addition to that question, what are the unique experiences of AI and AN youth?
Unique experiences of AI and so I think, and I feel like this is all healthcare in American Indian and Alaska Native communities, and Rydell spoke about it earlier. I think sometimes it's having that access, but not wanting to go receive it. So for example, like in my community, everybody knows everyone. That's like every reservation, every tribal nation, cousins working at the health clinic, like Rydell said. So I think a unique experience is I want to get tested, and we know confidentiality is a big thing in health, but sometimes it's just scary, like that gossiping. Like I want to go get tested, but my mom's friend is a nurse that would be testing me. Or what happens with insurance, right? Like I'm under 18 or under 17 and I need to get tested. And what if I test positive and I need medicine? Who's going to go to? Who's going to pay for it? So I think that's a unique experience growing up on the res. Our living on the res is they're going to find out this information. And although they talk about HIPAA and all of this, like I'm scared word of mouth is going to get out just because it's gossiping, or everybody knows everyone. Somebody's going to see me walk into the clinic and they're going to think, why is she here in the clinic? You didn't have an appointment today. What do you need? Or, hey, I know my clinic offers plan B, but if I go in, they're going to be like, what do you need plan B for? And of course, that's not how providers act with you. But it's just that experience being a youth, like who's going to say what to who and who's going to bill for this. I know when I was a youth, I would always think about that. Like if I am sick or I need condoms or something, and I know I'm speaking very transparently or candidly here, but that's just the reality of things. If I go into the clinic, is the program coordinator who provides condoms going to tell my mom because she knows my mom? So I think that's a unique experience to it. And also in my state of Texas, not to get political, but it's pretty conservative when it comes to like harm reduction techniques and sexual health. So that's a concern too for some of the American Indians or Alaska Natives who don't have a school system in their reservation, but attend a school outside that services the public. I'm not going to get this quality of care education because my school's not talking about it. So who do I go to talk about that if, it's a weird conversation to have with my grandparents? Who do I talk about this with? So yeah, I think that's probably a unique experience that I can speak to.
I think the unique experience that American Indian and Alaska Native youth face is pretty much who's the support at home, who is the natural support that can help navigate through all of this. And before the colonial experience, like I had mentioned, all of these conversations were open and education was being able to be provided. However, after the colonial experience, there was a major shift on how child rearing took place within Indigenous communities. On top of that, through the historical trauma that has entailed with a lot of Indigenous communities, have not healed. In regards to that. So we're not healed. We're having these we're not having these conversations. So our ancestors' traumas have become our traumas. And one thing that we need to teach, our Indigenous communities is that you are not your trauma. So being able to have those conversations and being able to, help the community heal, is what's unique about what's happening with Indigenous communities. And one of it, and I'm going to quote Don Coyhis here. Don Coyhis is the creator of White Bison, which is a program that he's created. And one thing he had mentioned was within healing, you can't just focus on one. You have to focus on all of it. And so what he means by that is we can have substance abuse programs. We can have teen pregnancy prevention programs, and we have suicide prevention programs, but that only focuses on just the tip of the iceberg. If we want to prevent and we want to heal, we have to heal as a whole. So that includes family, that includes community. And so being able to focus on that is what is unique about Indigenous communities in general, not so much about the programs that we've created or the programs we've developed, is that once these programs are developed, we don't just think about the individual, we think about the family as a unit and how we can heal as a unit. And so I think that's one thing that's unique is we're healing within as a whole rather than on an individual level.
Thank you. The next question we have is, what work is being done around storytelling to reach the youth of your population?
So I feel like Kelly is going to do amazing with this question, considering that you have, what was it called? Medicine Heals? Yes. So I think she can speak to this better than I can. But I think that it goes back to like Native Voices or just this programming using storytelling. And Rydell said it too earlier in the way he story told, they moved all of us. But I think in these programmings, whether it be through videos or through lesson plans and a curriculum, it's all centered around storytelling. Like if you're speaking to an elder or bringing up your community and your history of your community and how that ties into protecting your health and those around you. But I'm really excited to hear what Kelly has to say. So.
Thank you for that question. And I love that question in general. I think it's a beautiful question. I think from my experience and being Native, of course, a lot of Indigenous members, a lot of Indigenous communities, we are natural storytellers. And so, and a lot of people will see this as, well, just remember like they're natural storytellers. So they go on and on and on, but it's not so much that we go on and on and on. Our evidence is within our story. So we include Indigenous knowledge and Indigenous data with what we say in our storytelling. So when providers meet with patients or clients or individuals, especially an Indigenous elder, they will start back from when they're a child onto what's happening to them now. And most of the time you would think, okay, this is kind of irrelevant to the question I just asked you, but the evidence is in the story. And having the patience to be able to listen to that story. And so when we talk about Indigenous knowledge and we want to talk about, Indigenous data, it has all been foretold before even numbers were the research data or the research evidence in our collection. It was in our potteries. It was in our baskets. It was in the hieroglyphics on the walls. And so we've already had these original instructions in regards to how our story was going to be told. Now moving forward to now progressive, we continue to do our Indigenous storytelling. It is a part of our healing. It is a part of how we get to tell you how we became to be as the people. And so how that is unique within our Indigenous communities is we're giving the original instructions openly to these entities, to these organizations, to these providers. We're telling our story saying, this is what works. This is what doesn't work. Now, how is that interpreted? And so when it comes to westernized frameworks, we want to put all those in categories. We want to make sure that we're categorizing what's the priority and what's not the priority. But when it comes to Indigenous communities, we are all a priority. We are all of us as the people, our holistic healing comes from the physical and the behavioral health and the mental and the home style and the land and the resources. That is all who we are as the people. And so when we include that in our treatment, when we include that in our healing, that is the basis of ceremony. And so everything that we do is ceremony on this land. And so when we talk about, the land being a part of our mental health, when we talk about resources being a part of our mental health, we are telling the story of how, we became to be as the people. And so that is how, Indigenous art and storytelling has always been a part of our culture. And we don't call it Indigenous art storytelling. We call it our creation. We call it, where we came from. And so that kind of entails with introduction as well. All different tribes have different ways of introducing themselves. Within my way, which is the Navajo way, the Diné way, we introduce ourselves through clan. And with that being entailed, the indigenous, the Navajo or Diné, we don't have gender associated to how we identify ourselves. So me personally, I do not use pronouns when I talk about myself, because my pronoun isn't I'm a female. My pronoun is I am a Bitterwater clan. That's how I identify myself to the creator. I am a human being on this earth. So I don't say, hey, my name is Kelly, I'm the female. I say, Kelly and hello, my name is Kelly, I'm of the Bitterwater clan. That is part of also our storytelling and our identifier. And I think that is what's unique also about Indigenous people, Indigenous nations and communities. We don't see each other as, you're Cherokee, or we don't see you as Pawnee. We see you as another human being. And so within Diné culture, we call that Allah Ashkla'i, 5 fingers. And as humans, we all have 5 fingers. And so we're not, Ted the male, we're Ted the human. And so that's one thing that's unique about the art of storytelling and Indigenous art.
So thank you. We have roughly 20 minutes for some more discussion and some more questions. And so if PACHA members and folks in the room can start thinking about their questions or comments, and in a second, I'm going to sort of look around and see who might like to ask something. So very important question, Stephanie and Kelly. You guys have done a fantastic job at providing us with expertise. But I think from the point of view as a PACHA member, I think we all would love to hear your recommendations regarding what can PACHA do to better address the needs of American Indian and Alaskan Native youth? And what guidance would you provide us specifically?
I think on my end, being somebody who's native in an urban area, so I have my reservation, but we're literally located in smack dab El Paso. And as I mentioned earlier, we don't have our own schooling. We have schools outside the school district, and Texas being pretty conservative, I think there needs to be an emphasis on reproductive and sexual health of American Indian and Alaska Natives. How that might look for PACHA, not entirely sure, but just wanted to point out that importance of prioritizing that for our people.
I believe I might have mentioned something earlier in regards to this, and I do really appreciate this question. I'm going to be just candid in this area. I think one of the recommendations is more on the internal side rather than the program side. I think if you go to these conferences or even come to these meetings, you see all the programs that have been created by different organizations, by different agencies. You see programs that have been created by different Indigenous communities. And you see that the people are doing the work. I feel like there is not enough. There are entities that are being funded for programs that have already been established, but it's being named something else. And so through that, when it's being named something else, then people such as myself, professionals, have to apply for those programs, for that position. And it's like we're reinventing the wheel. And so that's kind of what I was mentioning, is that we already have those resources. We already have those programs. What seems to be happening most of the time that I've seen in the 14 years that I've been in this field was that we would have a resource about a wheel, and then someone says, hey, look, I invented this better wheel. It's just a little bit bigger. And it's like, well, we already have a wheel. Why are we reinventing another program? And now, me being a professional in this wheel, I have to apply for this bigger wheel, if that makes any sense. I also feel that in positions that there's not enough respect for some positions that are out there within the internal side. If you kind of take a step back and reflect in some of the conferences and some of the staff that you might listen to or hear, they would say things like, I'm just the case manager. I'm just a medical assistant. I'm just a medical case manager. Even just that word, language is very important. And so even hearing, I'm just this, I'm just that. You've actually heard Mr. Rydell Curley saying that. I feel like I'm small in this big world. And so where is that coming from? Why does he feel that way? Why do people just say they're just this? It's because they're hearing it from somewhere else. And so from my experience working in an integrated care facility, I am a case manager, and my job, I have more connection to the patient than the provider themselves. And so being told that I'm just a case manager and my recommendations mean nothing and there's no respect in that area, and is also a barrier. It also creates compassion fatigue. It also creates burnout, because you're trying to be the only one to care, yet your expertise is not important. And so I also think that's on the internal side as well. There's already programs out there that are being done. There's already people doing the work, but they're not getting that appropriate recognition, and they're not being thought of as a professional, but just the position that they're doing.
Sorry, I know we have some questions, and I don't want to sound disrespectful or rude whatsoever, but I do see like a lot of my Black, brown brothers and sisters in here. And I think whether it's around HIV, AIDS, whatever health issue, I appreciate PACHA coming to ask us, but I do ask that you all follow through. I think as Indigenous people or Black and brown people, we're always met with, hey, we want your input on this. Because we don't have Native voices or whoever on our team, can you give us advice? But I just don't want it to be short-lived and feel like we're only here for a panel and then we don't actually see any change happening. So I just asked PACHA to be accountable for us too, and actually go forward with what we're saying and implement whatever it is you are going to implement based on our recommendations. And this is coming from a place of historical trauma too, right? Mm-hmm. And feeling like, oh, you care about us. You know, like you're here for us, but then we get something taken away. So don't want this just to be like a waste of breath. Thank you.
Especially when it comes into body sovereignty. And I think that's one thing to also understand is public health also entails body sovereignty, especially within Indigenous communities. And so being able to provide that resource and just to speak bluntly, just because you have a program and you include a Native American drum does not make you culturally inclined or culturally sensitive. It's also being able to understand and being educated in the population that you are serving.
And I bring up my Black and brown brothers, not to put you all on the spot, but I'm sure you all can also relate to this feeling of historically, like outsiders coming in. And yeah, so not to put y'all on the spot, but just to, standing in solidarity and unity, I'm sure you all understand where these emotions come from. Thank you.
And making sure people are not creating decisions about your health for you and then bringing it to you and saying, this is what we've created together. And that's what I mean by body sovereignty, making sure that you're including those people that you are talking about. And in this sense, the Indigenous communities.
Thank you. So now we're going to open the floor for PACHA to ask questions. And I see Dr. Moore has his up, so I'm going to let him take the stand.
Thanks so much, Kayla and Benson. Great work. And I just want to also thank you both, Stephanie and Kelly, for your candor. So first, I'll just touch on the accountability piece, because I think that's so important. And thank you for raising that. Although PACHA is advisory in nature, we definitely take everything that is shared with us, and we're very active in listening and putting forth resolutions and things of that nature. We also have our PACHA to the people, which will happen this afternoon as well, wanting to hear from community and then be able to chart our course as far as who we need to hear from on the government side to be able to come back with recommendations and resolutions. So really appreciate you raising that. Also, I appreciate your candor around your use of "We Are Native" and how you spoke about that, and then how you got involved in the work, and then even how you mentioned being able to hire youth to pay them to write articles. So I was just curious, as we think about the next generation and passing the torch to that next generation, how important that is in all of our communities. What work is being done in your community to pass that torch, to the next generation of youth who then would need to do this work that you're doing and work in health professions to care for patients and people?
I'm really happy to see, like, when you look at the statistics of natives in higher education, that we keep going up a percentage, whether it be a bachelor's or a master's and so on and so forth. So with that, I'm very grateful that I'm well connected with a lot of native mentors of mine and been connected with them since I was in high school. So for example, you know, I'm like, oh my God, I'm still a youth. I'm so excited about that. But obviously I'm not going to be a youth anymore. And my time is no longer going to be shining because I need to let somebody else take this spotlight, right? So I think in that, there's a lot of mentors or native professionals that are mentoring the next generation. So for example, right now I'm being mentored by a lot of amazing native women, Donica Love Brown being one of them, Laura from the Northwest Portland Area Indian Health Board, that are teaching me. And in turn, I'm already mentoring native youth of mine. For example, that native youth writer that's in my community helping us with We Are Native. So I think a lot of it is professionalism. And I think, and Callie said it perfectly, we don't gatekeep anything. And that's what I love about my community or our community as Native people. If there's no gatekeeping, or there's no, this is only me, not yours. So from my personal experience, I think there's a lot of mentorship opportunity in tribal communities, and it starts now, so they can take on the next generation or occupy that next space. Does that answer your question?
It does. Thank you.
Okay, perfect. Yeah. And then also, like, Indian country has a lot of resources too, like fellowships, scholarships, a lot of opportunities for Native youth to get involved in their field. Like We Are Native has healers, We Are Healers, tribal colleges, have all of that as well. So like Indian Health Service, they have their physician program and all of that. I just can go on and on. But I think there's a lot of opportunity right now in Indian country that shapes youth.
All right, next we have Justin.
Kelly and Stephanie, you just gave us a tour de force. Like, that was incredible. So I just want to offer just like, wow. And I think I'm really, really thankful for the specific call out you made to Black and Brown people in particular, because I think that the other thing that I noticed as you were both giving your presentations, that there's so many similarities between our communities. And I don't feel like I can't think of a specific time in the HIV movement where Black people and American Indian folks have gotten in a space together and sort of share practices. And I feel like that's something that we can talk offline about that, but I just feel like there's something powerful in that sharing, because I think there is sort of a shared history of trauma in this country that I think bonds our communities. And I'm appreciative that you added in some Afro-Indigenous folks in your presentation and just kind of acknowledging the connections across communities. So the other thing I wanted to just affirm is that it was so powerful in all of the presentations today, how inclusive of Two-Spirit folks you were. And I think in this time where we're having so many attacks against LGBTQ people in this country, to have sort of a space that is welcoming and inclusive and intentionally so, like, and I think I'm blanking on the gentleman's name yesterday, but you talked about how, like, that's all, like, this is Western stuff about like homophobia and transphobia. Like, we don't do that here, right? And so just to have that sort of reflected through the presentations was really powerful. So I just wanted to affirm and lift that up. So I'm still processing everything that you all have shared because it was so powerful. But I feel like there has to be some more conversations across community, because I think that what you modeled was really how you infuse culture and listening to your people in all the work that you're doing. And I think that's a model for kind of how HIV prevention work should be done within communities across this country. So just thank you for sharing your brilliance with us today.
And thank you for that. And I think one thing that, Indigenous communities do is, as far as the universal law, we only have 4. In Western society, law has become so complex, especially within the justice system. But within Indigenous communities, we only have 4, maybe even 5. And that being going off of Verna Kirkness and Ray Barnhart, who are Indigenous scholars and authors from First Nations, respect. having respect for yourself, having respect for family, having respect for community, relationship. How are you building relationship with yourself and community? What is your responsibility, with being here in the glittering world? And that's what we call Earth right now. In this level, we call it the glittering world because everything has color to it. And then what is the reciprocity? How are we giving back? And what does that look like? And then lastly, reflecting on the actions, reflecting on the decisions. And so those are just the simplest universal laws that we can abide by. If we can apply that in everything that we do, then we can call ourselves healed. We can say that we're healing. We're on that journey for healing. And so that's what I try to implement in the work that I do, is implementing those 4 R's and then including the reflection at the end of that.
Thank you. Laura? No?
Wanted to share to your question, Justin, with mentoring the next generation. Some area health boards have youth delegates. So we do have about 13, 14 youth delegates at our health board. They serve 1-year terms and can serve multiple terms. And they basically learn about public health and policy advocacy and participate in our board meetings and get to address federal officials at those meetings. It's been really great. We just started doing more of that, and we hope to do more in the future. We also this week have our Thrive Northwest Native Youth Conference in Portland. It has about 100 attendees, and that's this week. And it's basically like a youth suicide prevention wellness focused event this week. So that's this entire week. It ends Friday. So I'll make the last day of that. So there are a lot of activities, and every area has, something going on.
Dr. Stewart?
Yes, so thank you again. Such great conversation and a continuum of earlier conversations. So my question, and this was kind of brought to my thoughts earlier, but again, it was kind of echoed with Stephanie. When we have youth and we want to get them into care and have those conversations about STIs, how have you found that, or what could be a process that we can use to continue to build that trust? As you mentioned, coming to a clinic or facility and, worried about, this may be a family member. And what resonated with me is that, in our rural communities, we see that, individuals afraid to come in, to get tested, to get care because, they may know someone within that clinic or someone may see them. And, a lot of times one is able to kind of alleviate that by having where I work like a community health center where you not only provide HIV care, but you provide primary care as well. But have you found anything that may work when you don't have that ability to, have just other type of care within a clinic or facility, and you want to engage that youth? Because again, I think things such as approaches that may work with the youth will definitely work with other individuals. So just wanted to throw that out at you.
Yeah, thank you for asking that question. I know we talked a lot about it being hard in a community, but how do you address that? And I find that peer-to-peer intervention really helps. So as opposed to a peer or a youth going to an adult, they can go to somebody who might be a little older than them, like a mentor. And we have those in my community, right? Like with their youth council, we have our mentors who are probably like 3 years older than the youth, but still like at the same age. I used to be one of those. And it's really hard sometimes. It's like, we're friends, we're also not, like I gotta be like a sister to you, but I also gotta be like a big sister to you. So I think peer-to-peer intervention really helps. So maybe even having an ambassador of your community and it can be something like disguised, right? So it doesn't necessarily be that the ambassador is working with the clinic directly that the community knows, but you can just become like the person in the res that it's like, oh, they probably have condoms on them, or like, I don't know, that might sound a little unrealistic, but I think peer-to-peer intervention is helpful. Maybe not in the sense of like, they're my go-to condom person, but in the sense that like, I have this good rapport with them and I can trust them. And if I have like a question, I can go to them. So I think a peer-to-peer intervention would help a lot in having youth engage in these healthy, safe sexual behaviors. I don't know, Kelly, if you want to add to that.
Yeah, and thank you for that. And I agree. I think youth to youth or peer-to-peer mentoring, because kids will listen to kids, right? And we have seen the numbers through the Healthy Native Youth website in those curriculums. We also have seen a lot of the supports through the Ask a Relative, Ask Auntie, Ask Uncle, and Ask Cousin as well. But it's also, one of the other things that I provide is youth mental health first aid for Indigenous communities. And one of those to be able to be the trusting adult that you can help, mentor the kid or help engage them in whatever services or just whatever programs, is just being able to allow them to be themselves. I think within the work that we do with the duties and the responsibilities, we have an obligation to make sure that we are performing and that we're providing the productivity. But I think if we continue to see these individuals as constant numbers rather than humans, it kind of takes away from building that rapport. And so being able to build that rapport and that relationship in a non-authoritative and threatening kind of way. You want to be able to be that askable adult. And one of the things that kind of gets adults is that they have this uncomfortable silence, but we like to call it the native pause. So when you ask a question, it'll just be quiet, right? And you're like, do I ask a follow-up question? And so we constantly have to fill that silent void by asking these constant questions. But what is really actually happening is we're processing the question so we can give an answer back. And so that's that native pause. And that's part of, communicating with teenagers, because sometimes you get, I don't know, and so just being able to be flexible and open to have that communication, be like, okay, well, when you think of something, come back to me, is not not being a helicopter and hovering over them, is giving them that option to say, hey, I'm here whenever you need it. And, just building that rapport in that sort of sense. And it is that simple, because remember, we're going back to the 4 R's. How are we showing respect? How are we building a relationship? What's our responsibility, and how are we giving back? And you'll get that in return from the individual when you model that as well.
One other thing, I'm so sorry, and then I'll stop because I'm sure we're running up on time. But another thing too is I think identifying your influencers. So just like social media, right? Like we're in the day and age of influencers who are pushing out product to consumers. I think you can identify your influencers in your community and approach them with, hey, I can see the impact you have in your community. Would you maybe consider being a peer in this aspect? So I definitely think that's important, knowing your community and who you think will really make an impact, whether they're a youth or young adults. So, yeah. Yeah, not reinventing the wheel, already utilizing the resources you have on res or in the community. I say res interchangeably with like the nation.
So we are close to wrapping up. We have one final comment or question from Tim.
Thank you. Great presentation. And I also want to give a shout out to Rick Evercake from IHS for being a great partner and helping to shepherd a lot of this forward. So kudos to him. Great comprehensive programming here. But I'm curious, is there a wish list of things you're not doing, things that you'd like to see? And what would those things be?
I think overall is my wish list for our communities, and even as a community as a whole, whether it's Indigenous or whether it's just us as humans, is just to be able to heal from those past traumas that we've all have endured, and to be able to work with one another in this world so we can continue to offer healing to those that really do need it. And I think in this sense, those that have suffered trauma or those that have had trauma are the ones that are actually giving a reaching hand out there because they kind of relate to what that looks like. And I think for me, there are so many other wish lists I have, like, more funding for better programs, more accessibility to resources such as internet, being able to, help a family pay for rent, help a family get food, being able to have family reconnect with each other, building natural supports, being able to have those healthy conversations, being able to decrease HIV and teen pregnancy, being able to reduce the traumas of substance abuse and domestic violence, being able to create these safe spaces for our two-spirited LGBTQ communities. There's just so many wish lists that I have, and realistically, we're building towards that. But if I could have a wish list right now that Rick could just grant me, no. Those would be along those lines. And with IHS, they're working on that. They really are. But good things take time, right?
I think my wish list is just echoing what Callie said, but also, and I'm really excited because I'm a member of the Indigenous I Want the Kid Advisory Board. So thank you, Rick, for that. But I think just access to testing, I think that's really hard, and just increasing that access to get tested. But again, I think there's really already initiatives in place that are doing so. So I'm really excited to see I Want the Kid expand further out in Indian country. But yeah, that's my main thing. Thank you.
So thank you. We've got 1 minute left. And before we say thank you to Stephanie and Kelly, I just want to share a couple of things, Stephanie and Kelly, that I heard you guys say. And just very briefly, I heard you guys talk very much about community support and the important role of community in HIV prevention and treatment. I heard a lot about alignment of services that are specific for youth. I heard a lot about incorporating expertise of youth, the importance of representation of American Indian and Alaska Native youth. Heard a lot about culture and language. Heard a lot about innovative approaches like the writing program. Heard a lot about encouraging our own development, the reference to education and seeking more education. Heard a lot about meaningful youth engagement. And lastly, I heard a lot about integrity and making sure the things that we ask of you, that there's reciprocity and that we honor and live those things. And so with that, I just want to say thank you to Kayla, to Stephanie, to Kelly, and to everyone for this terrific panel. Thanks so much.
And thank you to Dr. Vincent Guillermo Ramos and Kayla Quimbley for organizing and facilitating such an excellent panel. We are going to keep pushing along. We do have a scheduled break, as you can see on your agenda, post public comment. And so we do want to honor those individuals who have signed up in advance to be able to speak and lend their voice of experience and expertise with the council. So we will proceed right along. I will bid my adieu to you for today, and I will turn over the chairmanship to my co-chair, John Weisman. It's been such a great convening so far. Thank you all.
Thank you, Marlene. Appreciate your leadership and the important work that you're doing, not only here, but back home, which is what you need to go do, speaking of syphilis outbreaks, et cetera. So thanks for that. So just to give the framework for the rest of the afternoon. So our next piece is going to be public comment. People have signed up in advance for this comment. Folks will have 3 minutes to address the council. We don't really engage. We listen to what that feedback is, take notes. We do take it very seriously. It helps inform our work in our subcommittees and what we should be doing at future PACHA meetings, as well as perhaps influence what we are doing here today. Then we will be taking a break. And then we are going to do the sort of signature piece, I think, of the renewed and PACHA council, which is PACHA to the People, a community engagement session. This was where those of you who have been sitting and listening so well is also in the audience, and who come with your lived experience and your ideas, that we will engage with you. That will be a more unstructured back and forth dialogue discussion with you, with the facilitators of that, who I will introduce at that time. And for those of you who are online, you'll be able to participate in that as well. And we'll talk about that also after the break. So this piece is a bit more structured in terms of the formal comments. And then the PACHA to the people is really more of an engagement dialogue discussion section where we get to hear from folks who may be in sort of specific work in HIV/AIDS, who are from community, to really bring that lived experience, which is why we bring PACHA out across the country. And we're excited to be here. So with that sort of framework, I would like to turn it over to Kay Hayes to run the public comment. I will just remind folks that if you do want to give written comment, if you didn't get a chance to sign up, we also accept those. And you can send written comments to us at PACHA at HHS.gov. So that's PACHA at HHS.gov. And if we receive that by the close of business on Wednesday, July 12th, we will share all of those comments as well with the council members. So with that, Kay, I'll turn it over to you.
Great. Thank you so much, John. And I'd like to say we have our timekeeper, Chloe Loving, is in the back of the room. She is an ORISE Fellow in the Office of Infectious Disease and HIV Policy. So she will be our timekeeper. And just a reminder, John said it's 3 minutes. And listen for Chloe because she is the official timekeeper and want to honor and respect those that are presenting after you. When I call your name, please introduce yourself and then go on with your 3-minute comment. Our first comment will be virtual, and it's from Rupa Patel. Rupa Patel, to be a virtual comment. Colleagues, do you see Rupa on the platform? All right, I will come back then. Our next public comment is also virtual. It is from Wanda Brindy Moss. That comment is also virtual. She is online. All right, Wanda, the floor is yours. Let her know that she press star 6 on online. All right, Wanda, if you are on a phone line, please press star 6.
No, here I am.
We cannot hear you. Ah, great. We see you. The floor is yours, Wanda.
Hi, apologies.
We do not hear you, Wanda. Are you muted by chance?
Hold on.
No, we still do not hear you. We see you, but we can't hear you. Are you able to use a different microphone or mic?
Okay, can you hear me now?
All right, Wanda, our technical experts are going to work with you. Perhaps you may need to call in, so we're going to come back and circle back, all right?
Thank you.
All right, the next public comment is also virtual, and that is from Elena Ferguson. Elena? Is
Hello.
Elena on the platform?
Yes, I'm here.
All right.
Can you hear me?
Elena, the floor is yours.
All right. Hi, everyone. My name is Elena Ferguson, and I currently serve as the policy specialist at Positive Women's Network USA, a national membership body led by and for women and people of trans experience living with HIV. I also coordinate the Health Not Prisons Collective, which seeks to decarcerate public health. We are here to express concern about the ongoing dangerous practice of molecular HIV surveillance as it intersects with policing and surveillance of people living with HIV in communities most impacted by HIV. We have previously addressed the Council about our concerns with the lack of informed consent and privacy protections for sensitive HIV data in the face of rising human rights violations and attacks on queer, trans, and BIPOC communities. We are grateful for the leadership of this council in passing a resolution to address this important issue. However, we are outraged and disappointed that despite the council's dedication and hard work to make concrete recommendations that would mitigate the harms of molecular HIV surveillance, the Office of National AIDS Policy appears to be refusing to take this issue seriously. During the March PACHA public comment, people living with HIV went on record to publicly revoke consent for the sharing of health data related to their HIV diagnosis, genotyping, or any other related information. We hope that the council heard these concerns and took them to heart. It is unacceptable that the CDC continues funding MHS as a core federal HIV strategy while disregarding the concerns and concrete recommendations made by networks of people living with HIV, human rights advocates, privacy advocates, this distinguished council, and most recently, the UN Special Rapporteur on the Right to Health. The consequences of any form of criminalization can be long-standing and severe. The danger and long-lasting harms of medical information being shared in the context of criminalized identities or behaviors is neither hypothetical nor overblown. Recent data shows that in cases where adults were criminalized for seeking abortion care, people were reported to the police most often by healthcare professionals. And just last week, we found out that the health data of trans patients was released to the Tennessee Attorney General's office. Survivors of HIV criminalization can experience loss of privacy, custody of children, and employment. The federal government, including the CDC, must use every lever of power to ensure consistent and robust data protections, regardless of who someone is or where they live, and to uphold or at least stop violating the human right to informed consent for people living with HIV. Our work to elevate concerns with MHS and HIV criminalization is one necessary component of our fight to dismantle systems that perpetuate racism, oppression, and anti-Black violence. The lives and dignity and safety of the estimated 1.2 million people living with HIV in the U.S. depend on us taking these human rights issues seriously. It's networks of people living with HIV who have been leading the way in making sure these issues are addressed in the federal response. We urge PACHA to ensure meaningful involvement by people living with HIV networks in all aspects of decision-making about the lives and health of people living with HIV. And we look forward to collaborating with PACHA to demand a federal response that respects, protects, and fulfills the health and human rights of people living with HIV. Thank you so much.
Great. Thank you so much. Our next public comment is from Michael Blassingame. Please come forward.
Hi there. My name is Michael Blassingame, and I have been the Director of Data Services at HealthBana for the past 3 years. Some of you might recognize HealthBana from our patient engagement and PrEP adherence work with providers from the largest global HIV provider and Chicanos por la Causa here in Phoenix, who we've been working with for about 3 years, and whose director, Dubia Lozano, is actually speaking tomorrow. I just hit my 10-year PrEP anniversary, starting PrEP as an HIV prevention tool in May of 2013. And a decade ago, there was little patient advocacy. You had to fight for yourself to get on PrEP. My primary care physician, a gay man who likely lost friends and colleagues to the AIDS crisis, told me that I did not need to get on PrEP and that I was not a good fit. I had to be my own candidate. 10 years later, PrEP has undoubtedly changed the HIV landscape, but we have so much work to do. How can we continue to increase access to PrEP without placing the burden of this access on the individual? I am proud to work at a company that leverages technology to proactively intervene and advocate for potential PrEP patients, and then also accompanies these patients throughout their entire PrEP journey. The communities we serve have the most to gain from increased access to PrEP, as 65% of our patients come from non-white communities of color. And given the work that we do in test result delivery, we also have the ability to reach out to these individuals. In 2017, a study published in Sexually Transmitted Diseases found that people who test positive for rectal chlamydia or gonorrhea have a threefold increased chance of acquiring HIV, and that this can persist for up to 1 year. Because these folks are ideal candidates for PrEP, we are now piloting a program that schedules an initial PrEP appointment within 24 hours of a patient receiving their positive test result. And the data on this endemic approach is really exciting. In the first 6 weeks of this pilot, 37% of patients with a positive rectal STI result indicated they were ready to start PrEP right then. But just getting people on PrEP is insufficient. We also need to get them to stick with it. In 2018, a paper published in the Journal of AIDS cited a lack of adherence as a significant contributing factor to PrEP, not being as effective for many communities. We can address this gap through adherence monitoring to qualitatively and quantitatively measure PrEP adherence, and then communicate this information to patients and their healthcare providers. Building this relationship with both patients and providers may also help identify additional people who might need just more conversations around PrEP, or who may be better suited for different interventions such as injectables or other behavioral interventions. And although HIV and HIV prevention are complicated, meeting patients where they are at does not have to be. By building patient trust and advocating for our patients, we can increase both access and adherence to PrEP, leveraged by emerging technologies, which will ultimately help end the HIV epidemic. Thank you.
Great. Thank you so much. Our next public commenter is virtual. It's Amir Sahedej. Amir, are you on the line?
Yes, I am. Hi, good afternoon to the full PACHA Council and your distinguished guests today. My name is Amir Sadeghi. I use he, him pronouns. I am the Policy and Advocacy Manager at CHLP. We are an abolitionist legal and policy organization. We work to end the stigma, discrimination, and violence towards our communities experiencing racial oppression, patriarchal violence, and/or economic divestment. CHLP co-founded, along with the Zero Project, the first ever national collaborative to end HIV criminalization in the United States, the Positive Justice Project. So first, I would like to state that I support everything my comrade Elena just said from PWN. CHLP, along with other organizations and groups made up of and led by people living with HIV, are here to reiterate serious concerns about molecular HIV surveillance. How do we seriously engage with those concerns about molecular HIV surveillance when a resolution drafted by this body, by PACHA, was essentially blacklisted during a recent convening in Atlanta where CDC, NASTAD, and federal partners discussed, quote, lessons learned? How do we learn lessons when people living with HIV aren't being engaged in, quote, listening sessions? How do we learn and build trust in our public health system when the people most likely to face HIV criminal legal enforcement, including Black people living with HIV, sex workers, and people who use drugs, aren't engaged and aren't centered? Bodily autonomy and informed consent do not conflict with public health. We do not have two poles here where public health is on one side and bodily autonomy and informed consent is on the other. Even suggesting that, I believe, deserves a fierce reproach from all of us working in HIV policy, HIV clinical care, public health, and human rights advocacy. Entertaining the idea that there is a tension between public health and bodily autonomy isn't how we build trust. It isn't how we protect people who are every day at risk of having their health status and health data weaponized against them. According to NASTAD, 33 states permit the release of HIV data in response to law enforcement and court requests. 25 states use the general criminal law to target and punish people living with HIV. And as you all know, a majority of US states have HIV-specific criminal laws. HIV criminalization is not a fringe issue or a rare occurrence. Thousands of people living with HIV have been criminalized, have been confronted and dehumanized by our criminal legal system across the nation. These arrests are happening now. They will happen tomorrow. They will happen next year. Public health agencies, state and local and federal partners here need to recognize that that is the starting point from which we can even have a discussion about molecular HIV surveillance. To fail to start, this is my last sentence, I promise. To fail to start from that recognition about the reality of HIV criminalization gravely jeopardizes public health, undermines the safety of our communities living with HIV, and failing to start from this understanding will cost lives. Thank you.
Thank you, Amir. Thank you very much. Our next public commenter is Douglas Rose. Douglas is virtual.
Hi, everyone. I'm Douglas Rose. I'm talking to you from Baltimore, Maryland, and I am a longtime HIV activist. I've been working with lots of groups, including a number of people in this room, particularly on molecular HIV surveillance. But before I go into anything related to that, I just want to say how great this meeting has been and how exciting it has been for me to learn about how the American natives, the American Indians, are taking good care of their health despite the despicably low amount of funding they get from the United States of America. You know, I will also say that they actually seem to be very lucky because they aren't under the thumb of the USA, and they are able to develop some very exciting and innovative projects that could not be developed here in the United States. You know, there were a lot of things that were said today that caught my eye, but I want to go back to the beginning of the meeting and also this end of the meeting. You know, the last things we heard about were the 4 R's, and I can't name them all for you now, but they have to do with respect and etc. And I just thought, boy, you know, the American natives have that as a guide in their public health approach. I wish America had the same thing, because that isn't the way public health is working right now. It is working on, let's kill this disease, you know, and that, I'm afraid, may be killing the people who carry it. You know, the zero stigma plan is full of great ideas. I think one group that was maybe left out of that plan was educators. I don't remember educators being included as a rubric in that plan. But I know how hard it is to get nationally educators to do anything, but I think it should be in the plan. I think it should be stated. We want educators to educate their people. Thank you for the 1 minute. And as others have said, and as I will say, the message from Director Phillips today was just very disheartening and very similar to what I'm hearing locally here in Maryland. When you bring up MRS, they say, "Oh yeah, we're working on that, and we're implementing things, and you just don't know about it yet, and we're almost there, and we're going to tell you about it." And then they keep doing what they've been doing. And I think when he says, there are 80% of the recommendations being implemented or being considered. So maybe that means 10% are being implemented and 70% are being considered. We don't know. And then that 20% that they say no will have some detrimental effect on the public health is really, really very daring of them. Thank you for the time. Very daring of them to make as a statement, because I have yet to see where molecular HIV surveillance is better than any other kind of surveillance that's been going on. So thank you all.
Thank you so much. Our next public commenter is Terry Wilder. Terry is also virtual.
Hi, good afternoon. Thank you for giving me the opportunity to speak today. As mentioned, my name's Terry Wilder. I use she, her pronouns, and I'm the HIV aging policy advocate at SAGE. As many of you know, the CDC currently recommends that everyone between the ages of 13 and 64 get tested for HIV at least once as part of routine health care. These recommendations have not been revised since 2006. Knowing one's HIV status is vital for timely access to essential prevention and treatment services, including HIV medical care. However, most test and treat strategies have primarily focused on younger people, leaving older individuals behind. Older people account for around 17% of new HIV diagnoses in the United States, and they are more likely to be diagnosed with HIV at a later stage of the disease compared to younger people. In New York State, where SAGE is headquartered, in 2021, among individuals age 50 and above who were diagnosed with HIV, 35% were simultaneously diagnosed with AIDS, indicating a more advanced stage of the disease at the time of HIV diagnosis. Similarly, among individuals age 60 and above diagnosed with HIV in the same year, 37% were concurrently diagnosed with AIDS. This data clearly highlights that older individuals are not undergoing routine HIV testing, resulting in more advanced disease at the time of diagnosis and elevated risk of premature death. Everyone who acquires HIV benefits from prompt diagnosis and treatment initiation, and preconceived ageist ideas about older adults should not be a barrier to that care. Studies have shown that failure to consider an HIV diagnosis has contributed to delayed initiation of life-saving antiretroviral therapy in older persons with HIV. Early treatment is particularly important for older people due to decreased immune recovery and an increased risk of serious non-AIDS events in this population. A Lancet Journal article highlighted that studies have documented more missed opportunities for diagnoses among older individuals compared to younger ones. Therefore, we need to implement interventions specifically designed for older individuals with involvement from health systems, community-based organizations, people with lived experience, and the government. It is clear that routine HIV testing is not reaching older people, leading to delayed diagnoses and increased risk of premature death. So let me close by sharing a story I was recently told. A person diagnosed with HIV at the age of 79 only discovered their HIV status after changing to a new primary care provider who performed an HIV test. So this story raised some important questions for me. What if this individual, I am just wrapping up. What if this individual hadn't changed to a new provider? Would they have ever been diagnosed? And would they have gone years without knowing their HIV status, eventually developing advanced disease? So the potential consequences could have been devastating and possibly deadly. So thank you for your time and consideration. It's time to remove the upper age limit from the CDC HIV testing guidelines. And I welcome PACHA members and others in the room in joining efforts to advocate for the removal of the upper age limit of the CDC HIV testing recommendations.
Great. Thank you, Terry. Our next public comment is also virtual. It's Jeffrey Wong.
Thank you. I'm Jeffrey Kwong. I'm a nurse practitioner, a professor at Rutgers University, co-medical director of the American Academy of HIV Medicine's HIV and Aging Initiative, and a member of ANAC's HIV and Aging Expert Advisory Council. I too wanted to speak about revising the CDC's current clinical recommendations for routine opt-out HIV screening and removal of the upper age limit currently listed as age 64. This arbitrary age limit creates barriers to care for older adults and impedes the advancement of the National HIV Strategy and the Ending the HIV Epidemic initiative. Two key elements of the EHE are to diagnose all people with HIV, regardless of age, as early as possible and to prevent new infections. However, we cannot diagnose all people or offer prevention services if we do not screen them. Throughout my 26-year career, I have seen older adults present to care with advanced disease because they were not screened in a timely manner. One case that stands out was a 69-year-old with pneumonia who underwent an open lung biopsy for failure to improve after treatment with routine antibiotics, only to be diagnosed with pneumocystis pneumonia and advanced HIV. Had he been diagnosed 1 or 2 years before the age of 69 as part of routine care, he could have been spared from a highly complex ICU stay, saving him and the healthcare system hundreds of thousands of dollars. He is just one example of how the system failed, but there are many more. Additionally, rates of STIs such as gonorrhea, chlamydia, and syphilis have more than doubled or tripled among those over age 65. The CDC's screening recommendations for these infections do not have an upper age limit. CDC's HIV screening recommendations have not been updated since 2006, yet screening for hepatitis B and C guidelines have been updated in the last few years to reflect epidemiological trends. HIV guidelines need to follow suit. Finally, Medicare covers annual HIV screening for people over 65, quote, at increased risk. However, this limits access to care by using a risk-based strategy for those over age 65. To assess risk, one has to ask about issues such as sexual health. However, clinicians consistently fail to discuss sexual health with older adults. Data has shown time and again that older adults are rarely asked about sexual health during routine medical visits. If we relied solely on providers to determine if someone over 65 is at risk, a large proportion of individuals would go unscreened. It's challenging for anyone to ask for an HIV test. They may feel ashamed, embarrassed, or reluctant to bring this topic up because they don't want to be judged. Routine opt-out testing has minimized those concerns for persons under 65. We need to consider opening that same door and opportunity for those over 65. In conclusion, the highest rates of HIV transmission occurs from individuals unaware of their HIV status. By revising the HIV testing recommendations and removing the upper age limit, we have a chance to help end the HIV epidemic in the U.S. Thank you.
Great. Thank you so much, Jeffrey. Our next public comment is here in the room. Lupe Conchas.
Hello, committee members. My name is Lupe Conchas, and I have lived experience. I grew up in Prescott Valley, Arizona, and the first home that we had was an abandoned trailer that my father found in the middle of a field. He put it together for us with windows, doors, electricity, and gas. And I didn't realize that I was poor until I went to kindergarten and realized that there was a disparity there when I enrolled in the free and reduced lunch program. When I was 16 years old, my father was deported, and I decided to stay here in the United States by myself as my family moved to Mexico. In order to finish high school by myself, I lived in my car for about 3 weeks until I confided in a friend about my situation. I was able to go to the University of Arizona, and I was able to start a career in public service at the Department of Economic Security here in Arizona, and now I work for the One campaign as the Western Regional Organizer, fighting for PEPFAR, fighting for advocacy for HIV and AIDS and preventable diseases. I tell you my story because when I was on PrEP, one of my partners told me some misinformation that it would be bad for me, bad for my kidneys in particular. And so I stopped. And then a few years later, I was at a health clinic in Native Health. They took my blood sample and then they brought me into their care and they diagnosed me with HIV. I remember writing a letter to myself thinking that my life was over. And it was through Native Health, it was through Spectrum Medical Center that I was able to be undetectable and untransmittable and now be able to live a life of dignity and respect. But I'm here to advocate for PEPFAR, and I am asking the committee to use your positions and to use your positions individually and also as a committee to advocate for those who are dependent and not dependent, but who need PEPFAR. Because one of the things that I've learned from speakers is that you can have your daily medication, but you can't have it with an empty stomach and you can't have it with dirty water. And I have the privilege of having food and nutrition and clean water every single day here in the U.S. But on the continent of Africa in particular, we need PEPFAR to be reauthorized in order to save 25 more million lives, and especially with mother-to-child transmission. And we know that it is being attacked at the moment. And so I am asking this committee to please do something official, either as a committee to unify for PEPFAR or in your individual capacity. Thank you so much. My name is Lupe Conchas. I am the Western Regional Organizer with the One campaign, and I'm a community member, a school board member here in Arizona, and I'm also a person who is living with HIV. Thank you.
Thank you so much, Lupe. Our next public commenter is here in the room. We have Shruti Gurudandi.
Hello, everybody, and thank you for the opportunity. My name is Shruti Gurudandi, and I am with Televeda. We are one of the finalists for the Rural HIV by HHS. So again, thank you for the opportunity. I wanted to make two recommendations. One is, as an organization, Televeda is focused on alleviating social isolation and loneliness amongst underserved populations that includes AIAN community members. And we do that by bringing digital literacy training and broadband access along with socialization programs that are led by community-based organizations. The thing that we hear the most, and I heard both Stephanie and Kelly talk about this, is there are lots of programs that are available for the communities and that are available, but awareness is a big issue. People are not aware that these programs exist. And we hear that time and time again. Literally, we were at 3 different tribes over the last 2 weeks, and we heard the same thing that, oh my gosh, I just wish I knew about this program. I wouldn't have driven 50 miles, to get to the IHS or what have you. And so one recommendation would be if you could have some sort of a database or something online that gives or that provides all of the various programs that are made available so that people can sift through based on their location, their tribe, their language, and see what program might be best available for them. The second piece is, again, and I think Kelly and Stephanie talked about this, community-based organizations and community-based programs and groups are where really we need to be focusing on and empowering them. And what I mean by that is, instead of creating a program and saying, here, go run with it, this is what we think is best for you, communities are already doing the work. And if you really want to address stigma locally at the community level, we really need to be empowering the community-based organizations who are the trusted messengers, who have the trust in the community. So empower them, allow them to talk about the programs that you have, instead of having a top-down, and I hate to say this, but in the most blunt way, instead of being the white man going into a community and saying, here's what I think is best for you, empower the community-based organizations that are already doing the work by giving them the tools and resources to spread the word about the programs that you have. So thank you. My name is Shruti Guradanti. I'm with Televeda. Thanks.
Thank you, Shruti. Our next public comment is virtual. Ronald Johnson.
Good afternoon. My name is Ronald Johnson, and I serve as the chair of the steering committee of the U.S. People Living with HIV Caucus. I am also an older adult living with HIV, and I appreciate the opportunity to provide public comment at this PACHA meeting. I speak to add my voice to those who are calling for removing the upper age limit of 65 years on the CDC's recommendation on routine HIV testing of adults and adolescents. There are 2 points for removing the upper age limit that I want to highlight. The current age limit of 64 years increases the possibility, if not likelihood, of missing HIV diagnoses among people 65 years and older. We know the prevalence of comorbidities among older adults living with HIV and the related issues of polypharmacy. There is growing knowledge of the interaction between HIV and aging and the impact of that interaction on other health conditions, including those that are age-related. Increasing the number of adults who are 65 years and older and who are diagnosed as a result of routine HIV testing allows them and their healthcare providers to include HIV care in their overall health care and to look out for any impact of HIV on other health conditions such as cardiovascular disease and other age-related health conditions such as frailty. The other point I want to make is that removing the upper age limit for routine HIV testing is another step in addressing racial and ethnic disparities. According to the latest CDC HIV surveillance report, just about 2/3 of newly reported HIV diagnoses of adults 65 years and older were among people of color. It is not a stretch to think that misdiagnoses of HIV among adults 65 years and older are having a disproportionate impact on people of color. I thank you very much for giving me this time to comment on what I think, and many of us think, is an important issue.
Thank you so much, Ronald. Our next public comment is also virtual. Jenna Grant. Is Jenna Grant on the platform? All right. Our next public comment is from Jeff Berry, also virtual. Is Jeff Berry on the platform? All right. Jeff, the floor is yours.
Thank you, Kay, and good afternoon, co-chairs and members of the Presidential Advisory Council on HIV/AIDS and distinguished guests. Thank you for the opportunity to provide public comment today. My name is Jeff Berry. My pronouns are he, him, and I'm Executive Director of the Reunion Project, the National Alliance of Long-Term Survivors of HIV. Since 2015, the Reunion Project is the only national network dedicated solely to improving the quality of life for long-term survivors of HIV through local programs that are designed by and for people living with HIV and our allies. In a few years, almost 3/4 of people living with HIV will be over the age of 50. There are approximately 300,000 long-term survivors of HIV in the US, defined as people who were diagnosed before 1996. The Reunion Project holds an expansive view of long-term survival, which includes people who acquired HIV around birth or early in life and have been living with HIV for many years, also known as lifetime survivors. We hear a lot about quality of life, and it's great to now have long-term survivors and older adults with HIV incorporated into the revised National HIV/AIDS strategy. But I ask members of this committee, where is the sense of urgency? Many organizations have jumped on the HIV and aging bandwagon, and that's great. But after 40 years of this work, if we've learned anything, it's that a piecemeal or patchwork approach never works. We need a concerted, coordinated effort starting at the very highest levels from the ground up and infused at every step along the way. People aging with HIV and long-term survivors must not just be an afterthought, a working group, or an add-on to an existing program. We deserve better. To that end, we are calling for President Biden to appoint an HIV and aging czar to lead these efforts. The HIV and aging czar, working closely and in conjunction with ONF Director Phillips, will coordinate efforts across all federal agencies and with key community partners to prioritize the needs of older adults with HIV and long-term survivors. By meaningfully including us in the design of programs, research, and policies that will allow us all to thrive and age gracefully and with dignity. Much like people living with HIV transformed healthcare and research in the early days of AIDS through the HIV self-empowerment movement inspired by the Denver Principles, we have an opportunity to create a system that can be replicated and serve as a model for aging in this country and throughout the world. Let's not squander that opportunity. Thank you.
Thank you so much, Jeff. Our next public comment is also virtual. Jax Kelly.
Good afternoon, family. I am Jax Kelly, president of Let's Kick Ass Palm Springs, a 501c3 based in Palm Springs, California, that serves over 400 long-term survivors of HIV, AIDS, and witnesses to the plague years. Our community in the Coachella Valley is estimated to have between 2,500 to 5,000 people living with HIV over the age of 50. By providing social connections, HIV and aging, education, and advocacy, LCAPS seeks to relieve the stress from AIDS survivor syndrome and isolation that impacts our health. I'm a Black gay man over the age of 60 living with HIV since 2006, while I've been active in the HIV/AIDS community since 1991. I support recent efforts by NMAC and its National HIV and Aging Advocacy Network to seek changes in the Older Americans Act to include people aging with HIV as a population of greatest social need. In 2021, my state of California made this change in its version of the Older Americans Act, and I encourage advocates to seek similar changes in their own state laws governing their local area agencies on aging. It has become necessary for HIV and aging advocates to go beyond the usual networks of AIDS service organizations to seek a seat at the table where aging advocates are. Long before HIV impacted our communities, advocates were working on issues concerning our aging population. Medicare and Medicaid serve the healthcare needs of older persons in ways similar to Ryan White for people living with HIV. The federal government passed the Older Americans Act to respond to a lack of community social services for older persons, such as home-delivered and congregate meals, job training, senior centers, health promotion benefits enrollment, caregiver support, transportation, etc. I will continue to press for changes in Ryan White to support these services for people aging with HIV, while I ask our AIDS service organizations to become present in these spaces. I attended a statewide conference last fall in Sacramento to celebrate the first year of California's Master Plan for Aging. We highlighted 3 specific needs that cut across the myriad of constituencies represented. Caregivers, mental health, and homelessness were the top 3 priorities. I believe out of hundreds of attendees, I was the only representative of an AIDS service organization. This must change. More of us must be present in aging spaces. And please ask any AIDS service organization that addresses HIV and aging whether they are focused on caregivers, mental health, and homelessness. We must and we can do better. Thank you. I'm Jax Kelly from LCAPS.
Thank you so much, Jax. Our next public comment is also virtual. Pedro Coronado. Is Pedro on the platform? All right, going back, Rupa Patel. Is Rupa Patel on the platform? Wanda, is Wanda ready to present? Have we? All right. Great. I hear you, Wanda. The floor is yours.
Thank you. I feel kind of like the cow's tail. My name is Wanda Brindle Moss, and I am from Winston-Salem, North Carolina. I am an RN case manager, retired. I am a person with lived experience, having been HIV positive since 2002, diagnosed with AIDS in 2008. I will be 69 years of age on August 9th of this year, though my body tells me that it is more like going to be 79 years of age. I'm currently living with hypertension, atrial fibrillation. I'm a survivor of homelessness, though I am currently insecurely housed, and I live with food insecurity at all times. I am concerned about the issues of status neutral. I believe in theory that it sounds like a good plan, but I know that in my area, we do not have services enough for persons living with HIV. Currently, we don't even have an AIDS service organization in my area. And I live just 2 hours north of the designated ending the epidemic city of Charlotte, Mecklenburg, here in North Carolina. Sorry. And the lack of an AIDS service organization is catastrophic, as there's no one to guide people into services that they need. And unfortunately, our healthcare providers are not culturally competently trained into dealing with persons living. They treat us, but they don't really know us. The other issue that I have is regarding MHS. Okay, let me just wind up then with staying with status neutral. If we can't get to the services that we need, we're failing. We're failing as a community, and we're failing as a society, and that's unacceptable. 40 plus years into knowing about HIV. I thank you for your time and respect your work.
Thank you so much, Wanda. The last, Jenna Grant. Has Jenna joined the platform? All right. Thank you so very much. That concludes our public comment period. I'll turn it back over to Co-Chair John Weisman.
Great. Thank you, Kay. And thank you very much to those who offered public comment. Appreciate those comments. We don't normally respond to those, but let me just sort of do something not normal. My last meeting, why not? Right.
Go for it.
To those presenters who continue to share concerns around molecular HIV surveillance, I just want to say that the Council shares ongoing concerns. We have been listening to you. I think probably some of you may have heard my ask of Director Phillips after his comment about further engagement and wanting to understand in more detail the plans that they are indicating either have been in place or they're thinking of. So we'll talk a little bit more about that tomorrow and the follow-up conversation we had since our last meeting. But just want to say we continue to hear your concerns. we too have concerns, and we need to continue the dialogue. And so that's what I will say about that. In terms of the piece around the CDC screening guidelines, if the council's okay with it, what I would like to ask is that you empower the chairs through OIDP to inquire with CDC around if they have any sort of intention at this point around relooking at those, and just engage in a dialogue around what we're hearing, and start an informal sort of channel, not a resolution at this point, but if we could carry that forward. And I know our CDC colleagues are with us at the table hearing these as well, but if you could empower us, we would love to just, I think, check in on that and see what we can do about sort of moving that issue along. And unless anybody objects, we'll consider that sort of something that you're comfortable with. Great. Again, thank you for those comments from our presenters. It is an important part about moving our work along and listening to your lived experience and your concerns, which we will continue after break in a different format. So after break, we will have John Shapiro, who is a PACHA member, as many of you know, who's the director of Ending the HIV Epidemic at the Collaborative Research, LLC, here in Phoenix, and who you have been hearing from throughout the day, Laura Platero, the executive director of the Northwest Portland Area Indian Health Board, will facilitate the dialogue with you all who are here in the audience. And it will be a conversation, and I'm looking for my notes because our two Arise Fellows have agreed to, I had my notes all ready to go because I am terrible with remembering names. Way to go, John. And Kay is rescuing me here. Kat Kim and Stefan Tellone are going to help with taking notes and recording. Appreciate it. Those of you who know me know I'm terrible with names and memory on those, especially under pressure. But we do appreciate your help and assistance. So then we will, after that, just come back after the dialogue wrap up. And do a quick look at tomorrow. And with that, we will take a break and reconvene here at 4:45. So we'll give ourselves a 10-minute break, and we'll look forward to engaging. Hopefully those of you from the community will remain. And Caroline, do you have a comment?
Yes, thanks, John. Before break, for folks online, if you would like to participate in the PACHA to the People session, there's a link to register. It's different than the HHS live stream because the live stream you can just view, but we want to hear from you. So while we're on break, if you're online, we please encourage you to sign up through the link. Thank you.
Great, thanks.
Produced by the U.S. Department of Health and Human Services.